Today I'm going to be doing some vital signs, starting with Nicole's radial pulse. The minimum systolic pressure for radial pulse to be present is 80 millimeters of mercury, and the normal heart rate for an adult is 60 to 100 beats per minute. So I'm going to be checking Nicole's radial pulse for regularity, and if it is irregular, then this could indicate some abnormal cardiac functions. And I also want to check if the pulse is strong or weak. So I'm going to ask Nicole if I can take her radial pulse. Nicole, can I take your radial pulse?
Yes, you can.
So I'm going to be timing this for 15 seconds. So 15 seconds is up and I counted 18 beats. I'm going to times that by 4, which is 72, and that falls roughly between 60 to 100 beats range. I also noticed that Nicole's beats were regular and strong, which leads to no cause for concern.
Thank God, we're done.
Today is blood pressure. To start, you need to remove any restricted clothing from the arm, so I'll be able to place the blood pressure cuff high up on the arm. But first I need to ask for permission. So Nicole, are you alright with me taking your blood pressure?
Yes.
Let me know if it's too tight. So hold that. So you want to locate the patient's brachial pulse, which is on the medial side of the arm. Once you've located this, you want to inflate the cuff till you can't feel the pulse any longer. Once you can't feel it anymore, just give it one more squeeze and then go ahead and take your stethoscope. Take the stethoscope on the medial side of the inner elbow over the point where the pulse is red. You want to then slowly release the pressure till you hear the heart sounds. So the first sound is Nicole's systolic pressure, which was 120, and the point where the sound disappeared is her diastolic pressure, which was 72. So normal tentative measurements is systolic below 140 and a diastolic below 90. So Nicole's falls roughly between that range. A patient is considered hypertensive if their systolic is over 140 or their diastolic is above 90. So now I'm going to auscultate the chest, listening for volume and clarity of each breath. You would normally auscultate the chest anteriorly and posteriorly. However, for today I'll be doing an example of the anterior of the chest only. So first of all, you need to gain consent. So Nicole, is it alright if I listen to your chest? It may be a little bit cold. Yeah. Cool. So can you please take a deep breath for me through your mouth? So in and out, and in with the side, and out. Cool. So now I'm going to take a look at the lower lobes. Through your shirt here. So in and out. So we're going to go here. So in and out. So all of the lobes of the lungs sound clear and there was a good volume, which indicates equal air entry to both sides of the lungs. Okay. We're going to be doing some airway management. So first you want to tilt the head back to open up the airway. You want to then measure OPA from the mouth to the mandible, like so. And then when inserting the OPA, you want to insert towards the curved bit towards the mouth, and you want to twist at 180 degrees to avoid catching the tongue. Assess if the patient accepts the OPA, and also there's a couple of complications that can arise, such as induced vomiting if the OPA is too large, damage to the oropharynx, or worsened airway obstruction if you push the tongue posteriorly. So reasons for using an OPA is if the patient has a GCS of less than 8 or a scoring less than 2 on a verbal response. Another form of airway management is a nasopharyngeal airway using an MPA. You measure the MPA from the nostril to the mandible. So as you can see, this one is way too long for the patient, and this one is a little bit more appropriate for this patient. So you want to lubricate the MPA with a water-based lubricant, and then you want to insert it at a 90-degree angle to the patient's face. If you encounter any resistance, you can just twist it to a 180-degree angle and it will help with the insertion. If you encounter any more resistance, you can remove it and insert it into the other nostril. You want to insert it until the flange, so the top of the MPA, is reached the nostril. So the benefits of having an MPA is that you are not inducing gag reflex or vomiting. They can be inserted into a patient with high GCS scores and in a patient with trismus. MPA is contraindicated for basal skull fractures, and any complications that may arise are nasal polyps and or bleeding. Next, we're going to be doing a familiarization with the LifePak 12 ECG monitor and defibrillator. So before you start, you want to check the batteries, which are located on the back end of the machine. So just turn so the batteries are located under this flap, so just take this off. So these are the batteries, and to check the charge on them, you want to click the grey button, and the lights will show you exactly how much charge is left in the batteries. And if they are flat, you can just remove them like so, put them on charge, and once they are charged, then you can place them back into the machine. But just remember, when you do place them back on, you want to click the grey button once again to check if they are in fact charged. So to turn on the LifePak 12, you want to press the green on button like so, and we want it on manual mode, so we'll be clicking Energy Select, and we want to turn the dial to yes to change the manual mode, and we'd want to bring it back down to 50 joules for our test. So to do an operational test, you want to click Options, scroll down to User Test, and it will print out a user test for you. So when you did click the user test, it will print out this user test for you, and it will say the date and the time, and it will also say user test pass. So it does say user test pass, so the machine is good to use. So we also want to do a test defibrillation. So the left hand side of the LifePak 12 is the defib side. So we want to attach our defib to a test load. So, and we also then want to charge the machine. So you would click the orange charge button, and once the charge is ready to be administered, you want to then click the red shock button, and it will administer the shock. So everyone's all stand clear, and the shock will be administered. So to disarm the shock, it's a similar technique. So you want to charge the machine once again. But to disarm it, you just click the select button like so, and it will disarm the charge. We're changing from manual mode to AED mode. You can choose between the leads by pressing the lead button. It gives you a number of options, and you can simply choose whichever one you want, and it will come up on the light feed. So you click lead, the one you desire, and you can also then select through the channels like so. And if you want a specific lead, you can then also change that and have a look at that as well. So also to adjust the QRS volume, you can go over to the heart rate section, which is located here, and you can either raise the volume or lower the volume, like so. And also, if you want to change the amplitude of the ECG size, you can select the channel, go to size, and you can choose from 1.0 to 4.0, as well as you can also choose 0.25. So the ETCO2 detector is located in the right hand pouch, and it gets installed into the ETCO2 port here on the LifePak. So this is the ETCO itself, and also the non-invasive blood pressure button is located here on the LifePak 12. So also to change the ECG paper, there should be a spare roll located at the back of the life pack, like so. And if you want to change it, all you need to do is pull out the paper like so, pull out your empty roll, put in a new roll, and you want to then close the port like so. And you want to check that it is in properly, so you want to click print, and it will print out some paper, and then you know that it is actually in there. So also after you've done that, because when you turn the life pack tab on, it will go straight into defib pads mode. So in the left hand pouch you will find your defib pads. Here you'll also find your child lead ECG cables, and there will also be a bag that has a GTN, aspirin and a razor if you have a hearing patient. And also in the right hand pouch you will find your normal ECG leads, which are attached to me, your SPO probe, which is here, and your ETCO cable as well, your consumable, sorry. And also while viewing the live feed, if a lead was to come off, you would get a display on the monitor like so. So it'll be a dashed line, and this doesn't mean that it is a systole. So you would then just simply place the lead back onto your patient, and the monitor will be restored with their vital signs. For wound care and hemorrhage control, you want to check that you're wearing the correct PPE, so that is your gloves and your safety glasses. So you want to expose the wound and clean it with saline fluid if it is required. You can also pack the wound with moist dressings if necessary. But what you want to do is cover the entire wound with the smallest possible dressing to enable the maximum amount of pressure. So what you want to do with your bandage is fold it like so and place it on the wound area. So for a small wound you can use an adhesive dressing, but for larger wounds like this one, you want to bandage over the dressing, twisting and tightening the bandage each time it travels over the wound. So once you have dressed the wound, you want to check to ensure that the bleeding has been controlled. If the bleeding has continued, a second dressing or bandage can be placed on top, or you can choose to elevate the limb, like so, or also placing indirect pressure on the wound by placing a second bandage under the armpit area. For catastrophic hemorrhages, you want to apply a tourniquet, so this needs to be done at least 10 centimeters proximal to the wound. Once this is done, you want to tighten the windlass until bleeding has arrested or diastole pulse disappears. And if bleeding is still profuse, apply a second tourniquet, and always remember to record the time of application on the white tabs located on the tourniquets themselves. So now I will demonstrate how to use a tourniquet. So you want to apply it 10 centimeters proximal to the wound, like so. Twist the windmill and apply the time strap. So this is when you will then place the time of application on the strap itself, and also then feel for a diastole pulse and hope that the bleeding will have stopped. Okay. For an eviscerated abdominal wound, you want to apply a saline soaked dressing and also cover that with cling film. For a sucking chest wound, you'd want to use an inclusive dressing and cover with cling film. You can also choose to use a defib pad on the chest.